Welcome to the Oyer Visiting Professorship lecture. I'm going to just show actually a couple slides. I usually don't do this, but I thought this was a fun way to introduce Dr. Kelly. So does anyone know which state this is? It's not Wisconsin. It's not North Dakota. It's somewhere up there. It all starts in the state of Minnesota, where in the early 50s, there were three developing means of doing heart surgery. So one, on the East Coast in Philadelphia, a heart-lung machine was being developed. And then up in Minnesota, two individuals, Dr. C. Walton Lillehei, was developing cross-circulation, and F. John Lewis was developing total body hypothermia. And Dr. Norman Shumway did his PhD at the University of Minnesota with Dr. F. John Lewis as his mentor. So he conducted his surgical training and his PhD there, basically learning about hypothermia as a way to conduct heart surgery, and then further advance that to hypothermia as a way of protecting the heart, and then ultimately heart transplantation. So as we all know, Dr. Shumway is the father of heart transplantation. And Dr. Shumway, in all of his wisdom, recruited a young individual who had just graduated from the University of Chicago with his MD and PhD. And he came to Stanford to conduct all of his surgical training. That was Dr. Oyer. I think he looked a little younger than that, but this was his official Stanford photo when he was on faculty. And I think some of the younger people have not had the opportunity to interact with Dr. Oyer. But if you look at that picture, that's basically Dr. Oyer, and in terms of his personality. Well, Dr. Oyer became a very famous transplant surgeon, an LVAD surgeon, and he did the world's first successful LVAD bridge to transplantation right here at Stanford. Dr. Oyer also served as our interim chair in 2012 and 2013. And a few years ago, we held a retirement celebration for Dr. Oyer, and he looked quite glamorous at the time. Dr. Oyer is alive and healthy, and I talk to him every couple months, and he's still very entertaining and gives a lot of valuable advice, and was rather resistant to us endowing and naming this lectureship in his honor. When I called him to talk about this, he said, yeah, that's great, as long as I never have to show up. But I promise you, one of these days, we'll drag Dr. Oyer out of his cave and bring him down here off the mountains. He literally lives up in the mountains over there, and have him say a few entertaining words. So as our Oyer lecturer, we've invited Dr. Rose Kelly, who also obtained her medical degree from the University of Chicago. And she conducted her residency training at the University of Minnesota. So you can see some of these connections. She also became the Lillehei Endowed Professor and Division Chief. And she is also the CV Service Line Chief and a high volume valve, coronary, and transplant surgeon. And has achieved success in all three pillars of academic medicine. So she's been highlighted in the Minneapolis-St. Paul Top Doctors issue for about 15 or 16 straight years. And she's an NIH-funded surgeon scientist in molecular, mitochondrial, and stem cell therapies. She's a clinical trialist in coronary revascularization and also organ protection strategies. She's the residency program director. And then in national leadership, she has risen to be the secretary of the AATS, and is definitely the glue that holds that entire organization together. So with that, please welcome Dr. Rose Kelly as our Oyer visiting professor.
So this morning I wanted to first say I'm honored to be here. As you know, the Minnesota Connection, Dr. Sarah Shumway has been in our organization for her entire cardiothoracic surgery career. So I know quite a bit about Stanford from having met her father several times. And she absolutely confirmed Dr. Oyer was a meticulous surgeon. He did his research. He said he did all these LVADs in cows and translated it to the human experience, as was the tradition of surgeons. We take large animals experiments, make sure they're safe, and we translated them to the clinical realm. So it's truly an honor to be here. He had 51 years here. And as a surgeon scientist, I think this is exactly what we want to emulate. And I want to speak today a little bit about some of these innovations that I think that having the surgeon perspective, I was just talking to your residents, I think the scientists don't have the clinical connection and they're dying to have it. They need it, or they don't use their technical skills in the appropriate way. They get off track. So I want to talk about revascularization today. We're in the 66th year of doing bypass surgery. And when you think about it, the first time it was done was in 1960 with a vein graft, and it was using an anastomotic device. So it wasn't done with stitches. So I think they keep trying to get back to anastomotic devices. They don't work as well. But in 1960, this was done for the first time. It was only 8 years after the first open heart surgery had been done. By 1964, in Russia, Dr. Kolosov managed to do a series of 12 patients with a Lima to the LED off pump, which I find extraordinary. And if you look at the pictures, he's using very refined, iris scissors that he used to open that vessel. He was doing it off pump. He had shunts that he was using. And I'm just sort of stunned. Like, he just created all these things, and these patients survived. And he did not have angiograms. He had no guidance. They were doing it based on kind of exams, x-rays, echo, but not angiograms. And then by 1964, it was also being done in the US, but this was with vein grafts, similar to what you're seeing on the illustration. And it wasn't until 1967 with Dr. Favalero at Cleveland Clinic where it really entered the clinical realm, where people started believing this was possible. And he also partnered with his cardiology colleague to start doing angiograms. And that was just by mistake. They actually had the first patient arrest when they did a dedicated angiogram. They were able to resuscitate the patient, and they realized, oh my gosh, we could create a roadmap. So by literally 3 years later, they had done 1,000 operations and had become a clinical realm. And so today, we know this is like our most common operation that's being done is a bypass surgery. But we're treating really the #1 heart disease across the world. In the US, 700,000 people die of heart disease. And ischemic heart disease is the most common cause of death in men and women equally. It costs us over $100 billion to treat this disease. And we in the US still do over 300,000 elective or semi-elective CABs per year. That's down from what had been in the realm of about 500 and 600,000 in the 70s and 80s, as this really took off in popularity. So with this 66 years of having this, we've never developed an adjunctive therapy. We have absolute direct access to the heart, and yet no other therapies have been able to be developed to improve our outcomes with CAB. So I want to talk a little bit, chronic ischemic myocardium is what we deal with every day when we do coronary surgery. Ramatula in 1989 stated that the hibernating myocardium is sort of that muscle that's asleep, waiting to be woken up by revascularization. And it's really because you have decreased flow, decreased function, but you have the ability to recover viable tissue. So this is not, we never operate on infarcted tissue. We know revascularization doesn't work. But we also know that this ischemic heart disease is not only causing decreased function, it also has a stiffness that results in heart failure. So you have decreased contractility as well as decreased relaxation. And the more people are working, stressing themselves, being more active, the more they are developing symptoms. And ischemic heart disease is over 50% of people with heart failure. So more and more we're learning about how this dysfunction really is pervasive in both the relaxation and contractility. And our bypass surgeries have a huge impact. They've improved people's survival, but the functional recovery remains mixed. And when we look at, this is just a slide that points out in 2023, when we look at all the trials, the best candidates for surgery we now recognize are those who are diabetics, reduced ejection fraction, left main disease, complex multivessel disease. And those are the patients who are really going to get improved survival and symptom control. And it's better than multivessel PCI. We know that PCI now can treat symptoms, can recover STEMI and acute events, but medical therapy is often as good as PCI, and those are more recent trials. But CAB still remains better for all that. But it's really, we still aren't getting our maximal recovery. So this, I just want to point out, is what we usually see. This doesn't project quite as well, but this is the LAD tight stenosis, circumflex tight stenosis, and the right coronary artery barely, really tight stenosis in this patient. Oops. And I think I have to. I'm not sure why it's not moving. Oh, there you go. You can see a profound reduction in function. And this is, again, low flow, low function, but viable tissue. And when you look at, this is a patient after 3-vessel bypass. And he's just thinking about it. Well, trust me, it improved, but again, it wasn't profound. It wasn't back to the normal contractility that we're going to see in this heart. And this is reflected in the literature again and again. You'll get about a 10% recovery in hibernating myocardium, but it never goes back up to normal. And so these patients remain at risk for ongoing heart failure, reduced function, reduced recovery. And in the STITCH trial, from now many years ago, when they looked at low EF patients who got bypassed compared to optimal medical management, 16% had a long-term survival advantage over optimal medical management, but you had to make it out to 10 years. So this tells you again that this is a patient population that's not really being optimized, and ischemic cardiomyopathy remains a very high risk and lethal disease that we don't always think about it the same way we might as a cancer or other illness. So when you look up on the cardiology literature, what does our future look like? Advancement in coronary artery is really looking at diagnostic innovations, which I have to say are really cool. I think we're going to get away from angiograms. We're going to get into the single beat CT acquisition of imaging, where you can really look at the plaques, the calcium, but also the atheroma that can help you have patient selection improvement. You have interventional cardiology doing more drug-eluting stents development, pharmacologic breakthroughs, which are quite profound, actually. The SGLT2 inhibitors and the GPL1s are acting in a way we don't quite understand, but they are really reducing heart failure, and they're working really well in these patients. In the future directions, they just limit to nanomedicine and delivery of some of these drugs to the patient through intravenous or intracoronary development, or 3D preprinted vessels. But there's not a single mention of surgical changes. And I think some of that is because our surgical advances have been very technical. We've looked at op pump for many years, meaning without the bypass support, but there's not really been a profound clinical advantage to that, and it's kind of plateaued in clinical adoptions. You have total arterial revascularization, which is very guideline driven. It can really help people, but there are many caveats that impair broad adoptions, both from the patient selection and what they have as peripheral vascular disease. And finally, robotics, which is often limited to single vessel bypass, which we don't do very often, and it's very expensive. So these have been areas of surgical attention, but again, they're technical advances. And I want to point out that again, as we're surgical, that we are truly resting on the shoulders of giants as our pioneer history. And this, I just wanted to point this out. This is, as Joe mentioned, this is one of the first open heart surgeries we've done in Minnesota. That was in 1952. By 1954, Dr. C. Walt Lillehei was doing what's called cross circulation. And this is the parent over here. This is the father. And they were using the parent as the heart-lung machine. And this is the child here, and this is a photographer. And right in here, Sarah said this is her dad observing as a student in really watching these new operations being done. And this was driven by the patient need. These were really profound, sad instances of children just dying. And so these pioneers were taking high-risk cases and taking research animal. They knew the anatomy through their animal studies they had done. They had practice and practice, and they were ready to do these operations. But then they shared their knowledge. And I think that's what our pioneers did. He had over 35 surgeons from over 35 countries come to Minnesota to learn this. So it really spread this knowledge around the world, including Dr. Shumway, who ended up here. But this is a 50-year celebration. I just want to point out that these all were surgeon scientists. These were leaders in our field, from Castaneda to to Dr. Shumway here. We have Dr. Cooley, Dr. Gott, Dr. DeWald, all were inventors, all were based in surgery scientists. So I want to talk a little bit about some of the work we're doing at Minnesota as a way to kind of inspire you to continue to have a surgeon's perspective as you bring it to the sciences. So one of the new areas is in conduit development, because a huge problem with CABs is that the veins can get a fibrosis, stenosis, need to have further interventions over time, or the patients don't have conduits available to them. So working with our bioengineers, this is across the country, the development of surgical advances in conduit design. And it started out with more acellular synthetic materials, really were not as effective, and then moved into the synthetic polymer blends and hybrids with seeded cells, finally into naturally developed polymers, and really trying to design something that's going to be have no immunogenicity, not have a thrombogenicity, flexibility, able to handle the pressures of high flow. And eventually we've gotten into tissue engineering. And this is by self-assembly. And you can use 3D printing as the scaffold and then embed with the materials of the cells. And it was in 2009, these were really pioneered and brought to the clinical realm. And I just mentioned this because these are also, not only can they be made into tubes now, they can be made into sheets. You can do it as grafts. You can make them into valves. So this is an exciting development that the bioengineers have brought forward but they need the surgeons to bring it into the clinical realm. Because when you look at all the scaffolding they've developed from different tissues, 3D printing, they fabricate the scaffolds, and then they embed it with different types of stem cells, smooth muscle cells, endothelial cells, allowing these tissue engineered vessels to be implanted and then have the scaffold be replaced with the patient's own cells. And so right now, a lot of, again, large animal trials have been done, and then moving into clinical trials. And when you look at some early clinical experience, this was in 2020 using a peripheral arterial disease implantation of femoral arteries to the leg. This was in 20 patients that they did a 2-year follow-up. They had no graft failure. There were no graft-related deaths. One was an iatrogenic injury, developed a pseudoaneurysm that was easily repaired, but the limb survived using this artificial material. So this was in 2020. Again, larger vessels. This is what has been created at the U of M. They focused on acellular tissue engineered vessels. They have to externally support them with a nitinol support structure, because otherwise they were too soft and they couldn't conform to the heart and the stresses with that. What they have found in their animal trials is that they have significant tissue remodeling. The cellular infiltration, endothelialization, and the lamination provides a very smooth surface that they've not had clot or scarring develop. And there's no inflammatory response or hyperplasia. So they were doing this in sheep from the descending aorta to the LAD. And for up to now 18 months in sheep, they've remained patent with great outflow. And again, you can see just to the right how smooth the vessel and the conduit has become. Now, these are 4mm grafts. They're very much a prototype. This is not the final product. They're a very set length that they've created at this point. But they've moved into human implantation. Excuse me. And this was at 3 months. They did a CTA. And you can see here, this is the native vein that they used. and this is the conduit. But at 3 months by CTA, widely patent. And now they've gone out to 1 year. And again, it's very uniform, no problem. You'll see at the very top, there's what appears to be a stenosis. It's actually more created by the nitinol appearance. So it's not a stenosis of the graft internally so much as the appearance externally due to the nitinol cage that it helps keep the structure of the vessel. So these are very early studies, and this was just presented this past December. But it's exciting because if you can do this for patients who have no conduit to begin with, have a nice long-term survival. If these vessels turn out to be better than our native tissue, again, it improves your durability of your surgery. So that alone would prevent reinstrumentation, further complications of any sort of conduit development. So that's one area that I think is we as surgeons need to be ready to embrace and look at and consider, because conduits in the past have not always had the greatest durability, but I think this offers a new opportunity having this new technology available to us. But this is another area, this is more my area of interest, because I'm really interested in recovering the myocardium, that reduced function that doesn't quite come back to normal. Excuse me. It's really important to me. I feel like we're missing something. Because we know revascularization helps, and we know earlier intervention helps, and we need optimal medical management. I think these medications are fantastic. Excuse me, sorry. But what do we need to do to get the cells back to normal? Sorry. I had this happen once in a while. When we look at the mechanisms of injury, oops. This is related to mitochondrial function. This is regulation. Oh, thank you. And this is inflammation. All of these are increased when you have oxidative stress. With that signaling, you then have increased inflammatory markers that transform your fibroblasts into collagen producing and persistent heart failure. So how do we change this trajectory? You take your downregulated state of chronic ischemia, where you have viability but reduced function. And a lot of pharmacologic agents have been tried without success. But a cell-based therapy, it really has many ways of influencing the recovery. From remodeling, apoptosis, contractility, these are critical. But I also believe that the cardiac regeneration and neovascularization are huge areas of inquiry right now. We have our greatest chance to recover the cells at the matrix level. Many ways have been tried for stem cell delivery, from transcoronary sinus, transendothelial, transmyocardial. The problem is they thought the cells would embed or transform into cardiomyocytes, and that just doesn't happen. And so we need to think of ways that you can get these signal to stay in the heart. And for us, that has been using a stem cell patch. And this has been a mechanism that others have also investigated to some varying degrees. And what you embed and how the cells stay is very important. But to study this, we went back to our roots using a large animal model. So what we want to do is you take small animals, a pig, which has the most similar structure in their heart to humans because they don't create collaterals. So if you put a stricture on this left anterior descending artery by just placing a fixed 1.5 millimeter constrictor, the animal grows into that and creates their own stenosis over time. So it takes about 12 weeks of growth. And by that time, you have a significant stricture. I'll see if this plays. Where you have whoops. You can see a very tight, over 80% stenosis very consistently occurs. This allows us to really study these animals, understand hibernating myocardium from like what's the problem that we're starting with, how can we treat it? And what our initial studies have shown is that when you have a change in EF and hibernating myocardium significantly lower than normal animals, is particularly when you are stressed under a low dobutamine infusion. And the same is true for relaxation. So the PV loops show a significant drop in hibernating myocardium. They're not able to relax normally. And we study all this using MRI because it's a little more precise in regional dysfunction compared to echo or CT imaging. And when you look at the cells, you can just visually see how deranged the mitochondria become in hibernating myocardium. You lose the structure, the connectivity, the size, and that all reflects what we see then in the stiffness of the structures and their decreased function. So we actually did a single vessel Lima to LAD off pump, kind of like Kolosov. And we do this as a second operation on these animals. So they're now going to live another 4 weeks to allow for us to do the LAD. And you can see, let's see, ran a little quick. Try and get it to run again because I want you to see that you have the proximal stenosis that persists, but it doesn't occlude. So we're not dealing with an infarct model here. You can just see a little more proximally. And that's really important because almost every other animal model that's used is an infarct model. And when you do that, you're dealing with a very different situation because now you've gone to scars not able to be recovered. But what we found, when we looked at the hibernating myocardium, we knew, okay, we had decreased function in the LAD territory in particular. When we did a bypass at rest, it went back to normal. So like we see in our patients, their recovery comes back. But when we stress them with the dobutamine infusion, they remain statistically less recovery, less function than the normal remote tissue of the same animal. So the animal is serving as their own internal control. And then we looked at, and I won't do all the basic science that we have looked at, but I want to point out that when we looked at these animals, whether it was inflammatory markers, in hibernation, you consistently have a very high response. So these animals, even out to 3 months, are having a constant inflammatory impact. And it again gives you the indication when the pharmacologic treatments are anti-inflammatories, they're really addressing a key pathway of injury. But when you bypass them, it comes back down significantly. You know, there's definitely recovery. It just never gets back into your normal. When we did this looking at the mitochondria, and you get to remember your Krebs cycle and everything, it's very exciting. But in electron transport chain, where you're making your ATP, all of that is severely reduced in hibernation, which is a light gray, but when you revascularize them, they never go back up to what the normal is. So there's a continued mitochondrial injury as well. So we had looked at other pharmacologic additives in this animal model. Nothing made any difference. But then we thought, okay, we're going to try stem cells. And by the time we were doing it, many people had given up on stem cells. They were putting them into infarcts. They weren't engrafting. They weren't creating new cells. They weren't contracting. But everybody was seeing that the peri-infarct areas were getting better. And that's like hibernating myocardium. So they're kind of on the fringe. They're ischemic, but they're not dead. Oops. And so from our own animal models, we created the bone marrow biopsy, cultured stem cells, and we put them onto a mesh, like the vitral mesh, because it happens to be the right scaffold size that the cells could ingrow. And it's very simple. Here's the Lima to the LAD, and we just attach these vitral patches, but they had to come out of the incubator. They had to be right in real time with the experiments. So a little clunky, but you know, it was a good start. And I for sure thought this isn't going to matter. We've tried everything else. This isn't going to work. I can't believe we actually think these cells are going to make a difference. But the amazing thing is, when we just compared it to our historical animals here, where the wall thickness was at this point, when they are at rest, there was no statistical difference. So it didn't help at rest. We'd already kind of gotten back to a baseline. But when we did the dobutamine infusion, we actually saw recovery that we never saw in CAB patients alone. And that you know, it's kind of like those moments in science where you're like, oh, okay, we're going to keep going because we actually found something that was interesting. But again, when we looked at, this is, again, the PGC1 alpha is the mitochondrial master regulator. Again, significantly improved when you used MSCs compared to hibernation, certainly, but even with CAB. And when you looked at this is again, kind of a master regulator of inflammation, really high in hibernating myocardium, better in CAB, but most significantly reduced in when you use the stem cell therapy. So we were in 2023, I just looking back, there was 7,000 stem cell therapies, clinical trials being done. Now this is in orthopedics, this is, you know, in every specialty, neurosciences, cardiac. And the advantage is they're easy to isolate and replicate and produce. They have some engraftment, they have these clinical studies, and it's a well-established guidelines. But at the same time, people weren't being effective in heart failure after implantation, after infarct, in cardiac trials. So people were really losing faith, but they were finding that it was probably not engraftment so much as a paracrine signal. And so that's when exosome therapy, because that's basically the cell's own creation of a signal, creates packets that come off of the cell itself and allow signaling. And they carry these, what they call payloads or cargo of microRNA, siRNA, proteins, small molecules, all of these signaling materials that don't require engraftment, but it's actually how cells talk to each other. So it could be coming from mesenchymal stem cells, fibroblasts, other cell lines, but all of these are ways the cell is doing this. And we actually did some in vitro studies taking cardiomyocytes and then the media from stem cells and did the seahorse trials looking at mitochondrial function. Like, are they able to produce ATP and how is that affecting the electron transport chain? And when we added an inhibitor of the exosome release to these cells, the improvement with the stem cells went away. So we actually thought the exosomes and for us, and probably extracellular vesicles, so not just the tiniest packets, but probably the whole spectrum, is probably the signals that the stem cells are using. So then we created, we went from the stem cells on a vicral patch to creating the extracellular vesicles. And we did this by starting with the MSCs in a hypoxic conditioned media, so they were stressed. They're not just like sitting around kind of quiescent. If you don't stress them, they probably don't have the same signals. And we wanted to use the signal they were likely to see in cardiac situation. We were able to isolate them, and we put them onto collagen gel foam. And this is again where speaking with our bioengineers, they said that's going to be the right size for this size of extracellular vesicles. And gel foam is what we use every day in the OR. So this is not creating a new device so much as a pharmacologic pathway of therapy, making it much simpler for translation into clinical. So that was me as a surgeon saying, I don't want to create a new delivery system. I want to use what we have and deliver the stem cell signal. And then we just placed it in the same way right onto the epicardium at the time of surgery. We then compared our groups. So now we have our groups with just the hibernating myocardium compared to CAB, and CAB with exosomes instead of a stem cell patch. So very similar studies. But this is a little bit simpler because now you just have to draw it up in a little vial because these are all your concentrated exosomes. And we have the how much is in there and the concentration, that sort of thing, based on our NAT testing. And then you inject it directly onto the collagen. And then we did 2 experiments just to see is there any uptake. So we did just normal animals at 20, put it on as a sternotomy, just put the patch on, sewed it in place. And at 24 hours and 72 hours, what we found is over here that there's certainly uptake into the epicardial tissue here, but it tends to gravitate towards a lot of fat tissue. But even at 72 hours, although it's no longer where the patch is, it's again really embedded into the epicardial surface of the heart. And we still had signal here and here that the exosomes were present in the patch, which is important. So I consider it a sustained release of the exosomes. So after you do whereas if you inject it into the coronaries or into the veins, it's going to be dissipated immediately. these patches really do allow a sustained release of the exosome over time. As if you think about a bypass surgery, the first couple of days are pretty rough, a lot of inflammation still, a lot of injury still. But if the cells are recovering and still have a signal for additional recovery, it's happening maybe at 4, 5, or 6 days. So then we were thinking, okay, how do we, when you have them stored, you have a time frame of about 2 weeks before they start to degrade. And this is what you can see here on the patch. It's the same thing. I secure them in place with a Vicryl patch because you have the Lima, because the gel foam doesn't stick in the same way, and I wanted to make sure it stayed on the epicardial surface. But you can see with drawing it up in the fluid, and you have to have it on the shelf frozen at -80, that's again hard to translate into clinical practice. So we started doing basically lyophilization is the freeze drying of the fluid. And we were able to see that you can reconstitute that out of and have it on the shelf at room temperature. And when we did these studies, we looked at our fact that with our MRIs, similar to what we'd done in the past, we had, again, the EF, which is reduced in hibernating myocardium, improved slightly with CAB. And then we had, and then this is a group that we did just with the MSCs alone. Again, you really need both to get the sustained improvement. And we found that with extracellular vesicles alone, it was as good as the intact cells. So now we're starting to do something that can actually translate into the operating room. And we did this with diastolic dysfunction as well, and even this was even greater. I think a lot of that signaling is again reducing the inflammation and the translation into myofibroblasts, which are causing scarring. And all these animals have been given about a month to recover. We did one small group that went out to 3 months and saw no difference between 3 and 1 month. These animals get really large, and 3 months is about the best we can do. And so we don't take them out that far. We have not seen an advantage in doing that for more time of recovery. And when you look at this is probably, and these are select slides, so you can kind of pick any slide you want, make it look good. But when we worked with a blinded pathologist, actually not blind, pathologist blinded to the information, she was able to be very meticulous on where she took the sections and what she looked at. And this being your normal myocardium, you can see hibernation has a lot of collagen laid down, absolutely. And I would think this is permanent, like you're done. But even when you do a CAB, it starts to resolve somewhat. And this is with MSCs alone, but when you combine it, you really get a profound recovery. And I think, again, this is just an indication that something's happening. So when we talk about commercialization, now you want to, again, translate into bring it back to the patient. This is where, again, the scientists in the lab get very excited about the methodology, what's in the cargo, how big are they, how do we reproduce them? All of that's important. But you can get so far in the weeds that you'll never bring it back to something that's clinically useful. But when we did the lyophilization, this is where you freeze dry it down into this little pellet almost. You can store this for over a year, and this is not just our lab. This is what is being done with exosomes and extracellular vesicles by many researchers. You can store it for a year at room temperature. So now you can ship it, you can take it off the shelf. There's no immunogenicity to it. It's a very, very safe therapy. And then you just reconstitute on the field in the OR like we do for many things, right? You can use the gel foam, put it in there, again, an off-the-shelf thing in the operating room, and secure it to the heart. And you can do it. I don't know that you have to be in the area of ischemia, because as you saw, they kind of go wherever they want, but they stay in the region of the heart. And I think, and I don't know the optimal dosing, because you can concentrate it. And you can also use these extracellular vesicles. You can sort of direct the cargo they deliver. But it's all cell-based. There are other therapies that are out there, like nanoparticles, where you can kind of control what's in a lipophilic package. But this strikes me as kind of the most straightforward, because these are what the cells are already using to communicate with each other. So they embed in the other recipient cells and deliver their message without having to embed in the tissue itself. And it really allows us to have an off-the-shelf therapy that we can use at the time of bypass surgery that adds about 5 minutes to the operation. Very safe when we do the reoperation. We explant the hearts. There's no more adhesions than you'd see in any other redo. There's no particular adhesion to the area of the patch. All of this is maybe pretty hopeful that we can actually do something that can impact our patients beyond revascularization. And this is just a study we did looking in vitro. What we did is we have a fluorescence on the membrane of the extracellular vesicle. And this is showing basically that the uptake is into the cells of the cardiomyocytes. And that whether it's lyophilized, you can still see that it's embedding here, the same as if they're not, letting us know that we are not destroying the extracellular vesicles by the process. So in summary, I just want to reiterate that coronary artery disease is our most common disease that we have to deal with as cardiothoracic surgeons. It all leads really to decreased heart function. When you think of the mitochondrial damage, the inflammation that occurs due to chronic ischemia. And the treatment we have been doing for years improves survival. We know we're doing the right thing with these patients with complex disease. But I believe that exosomes, stem cell therapy, and probably many other gene therapies, regenerative therapies have the potential to increase mitochondrial health, decrease inflammation, and really increase your heart function. So taking it to the next step. And I think we need to partner more and more with our scientists, our pharmacologic partners that can help us deliver this at the time of surgery when we're there in a way that no one else can reach these patients. So my conclusions are it really will be biological advances that will improve our therapies and take care of our patients and enhance their myocardial recovery. And surgeons need to drive this innovation because we truly are the ones at the bedside. We know what our patients need, and we have direct access to the myocardium to improve the care. Thank you.